Thank you. Greetings from India. Uh, is my screen visible to all?
Yes.
So at the outset, I would like to thank the organizing committee and in particular Dr. Shana Parveen for the kind invitation. And I have been given the task of giving a brief overview on radiotherapy in endometrial cancers. And I have taken the liberty of putting it as adjuvant therapy because most of the treatment is in adjuvant setting. In whom, when, and how. And I've written it as an update so that the guidelines which have come in recent past will be helpful for this talk. I have no financial disclosures. Before we go into the details, this is a very basic slide which shows in short what are the basic principles. Surgery is the mainstay of treatment for endometrial cancers. Important is the surgical pathological FIGO staging, and I always tell that the operating surgeon, the gynecologist, and the gynae pathologist are the most important prognostic factors. And the reason for that is that clean surgery followed by a detailed histopathology is mandatory for defining and deciding on the prognosis as well as treatment of endometrial cancers. And in short, the histopathology definitely should include the histopathology type, endometrioid, serous, clear, etc. Then the next important factor is the grade. In the past, we had WHO grade 1 and 2 and 3. Now the FIGO has come up with binary classification into low and high grade. The low being WHO grade 1 and grade 2, high being grade 3. The next important factor is the depth of myometrial invasion, less than 50% or more than or equal to 50%. In the recent past, the most important pathological factor which has been extensively researched and studied and a lot of guidelines have come is because of the lymphovascular space invasion. And the pathologist has to be very careful in defining these, whether LVSI is present or is it focal, or define it as a substantial if the diffuse LVSI is seen in microvessels, or there are more than 5 lymphovascular spaces involved. The lymphadenectomy role is not well defined. I will not go into the details. It is more to gynae-oncologist to decide. And last important point is that in patients who are high risk by virtue of severe comorbidities, elderly age, obesity, cardiac issues, diabetic, severely diabetic, in such patients in recent past, radiotherapy alone has been offered to these patients in the form of brachytherapy alone or a combination of external beam and brachytherapy with reasonably good outcomes and comparable to what has been shown with standard treatment. This is a table which, in short, suggests which patient should undergo a lymph node dissection. Patients in low risk, that is grade 1 or grade 2 with superficial myometrial invasion, lymph node dissection usually is not recommended. In intermediate and high intermediate risk group patients where deep myometrial invasion is seen or the high grade tumor is seen even in superficial myometrial invasion, such patients would definitely go for at least a sentinel lymph node biopsy, which is a big area of research in recent past few years. However, what is important is in patients who are high risk, that is grade 3 tumors with deep myometrial invasion or stage 2 or stage 3, definitely these patients should undergo lymph node dissection as a part of radical surgery. In last 10 years, there have been several recommendations and guidelines for the treatment and follow-up. For example, there were ESMO guidelines in 2009. Then subsequently, there were French guidelines in 2011. And in 2013, the Italian guidelines. What was more extensively understood and were helpful in the treatment in the routine clinic was the ESMO, ESGO, and ESTRO guidelines, where medical oncologists, gynae-oncologists, and radiation oncologists had a consensus conference, and this came up in 2016 and which were updated in 2017. However, for this talk, I would like to highlight the latest guidelines which has come from Gynae-Oncology Society, Radiation Oncology, and Pathology Society from Europe for the management of patients with endometrial cancer, which has come in 2021. So the highlight of this guidelines is that in recent past, molecular signatures have been incorporated for endometrial cancers. As Dr. Bafram mentioned earlier, that distinct 4 groups of endometrial cancers can be classified according to the molecular characteristics. And these molecular markers are in the form of poly status, then the mismatch repair deficiency or non-specific molecular pathology, and last is the P53 status. And the reason why this has come in recent past is that if patients have polymutated tumors, they have excellent prognosis, whereas if patient has P53 abnormal tumors, they have poor prognosis. And in the recommendations and guidelines, recent guidelines, molecular classification has been encouraged, especially in high-grade tumors, so that we can tailor the adjuvant treatment according to the classification. What is important, and Dr. Bafna did mention that polymutation is usually done by DNA sequencing, which is not very easily easily available in most parts of the world. However, it is very easy for the immunohistochemistry to be implemented in various settings. A word of caution, you do need a good pathologist and interpretation for these IHC studies so that the molecular classification can be implemented very easily in your departments. So what these guidelines have recommended are the prognostic risk groups. On the left side of the slide, I have shown the 2016-17 risk groups into low, intermediate, high, and advanced or metastatic disease. In the right half of the slide are the 2021 guidelines, which are more or less same, low, intermediate, high, as well as advanced or metastatic. It's very important for you to understand the various tumor characteristics which have been classified into these groups. It is very difficult, but I have tried to make it easy based on whether molecular classification is known or unknown. And for that, I would just like to highlight certain differences which have come in last year's recommendations. Earlier, the high risk group had quite large variables, including stage 1, grade 3, more than 50% myometrium invasion, stage 3, stage 2, and stage 3, and then non-endometrioid, that is type 2 histology, were classified as high risk. However, now we have some literature which says that stage 1A non-endometrioid without myometrial invasion have relatively good outcome with or without treatment. So this has been shifted from high risk to intermediate risk group. And secondly, the stage 2 who undergo a good surgery and treated with adjuvant treatment, they do have a reasonably better outcome than high risk. So this has also been shifted to high intermediate rather than high risk. How do you remember in your routine clinical practice? On the left side, what I have mentioned in red, here you can appreciate that you need to have the information on the depth of invasion. You need to have the information on the LVSI, and that with these two information, you'll be able to classify them into low, intermediate, and high intermediate. For example, low risk group are patients who have stage 1 and stage 2 with no residual disease and polymutated and LVSI negative or focal. In intermediate risk group, they are patients with stage 1B low grade or stage 1A high grade with LVSI negative or focal. And as I mentioned earlier, for P53 abnormal stage 1 non-endometrioid histology without myometrial invasion is classified as intermediate risk. Whereas if patients have substantial lymphovascular space invasion, and if they belong to stage 1A low grade or stage 1B low grade or stage 2, these patients would be classified as high intermediate risk. And the remaining patients, including P53 stage 1 to stage 4A with myometrial invasion, type 2 histology, or stage 3 to stage 4A with no residual disease, would be classified as high risk. And these were based on various outcome studies from POTEC 1 and POTEC 2 study. Here I have shown an example of the publications from POTEC group, where you can see clearly that patients with P53 mutations have higher locoregional recurrence, higher distant metastasis, and poor overall survival as compared to poly, who have excellent outcome for these various endpoints. On similar lines, for type 2 histology, again, these graphs show that the molecular classification becomes very vital for the treatment. Coming to who would qualify for adjuvant treatment, And for the benefit of the residents and young faculty, these are the practice defining landmark studies, randomized trials, namely the MRC STAC trial, POTEC 1, POTEC 2, POTEC 3 trial, GOG 99, GOG 249, and GOG 258. These are the various randomized trials which are very important, which have really classified the adjuvant treatment for endometrial cancer. And today we are in a position to really practice evidence-based radiotherapy for these patients. So coming to the first group, that is low risk. If you have no molecular classification for these patients, if they are stage 1A, endometrioid, low grade, LVSI negative or focal, you could offer them close observation rather than giving adjuvant treatment. And this is based on MRC STAC and POTEC 1 trial. For intermediate risk group, which consists of stage 1B, low grade, LVSI negative, or stage 1A, high grade, LVSI negative, or stage 1A, type 2 histology without myometrial invasion, these patients either can be offered adjuvant brachytherapy with the level of recommendations being level 1 evidence, grade A. And this again comes from the POTEC 1 as well as GOG 99 study. And alternatively, if these patients are younger and surgery is complete, such patients, especially less than 60 years, could also be offered a close observation for intermediate risk group as well. However, for high intermediate risk group patients, if patient has undergone lymph node sampling or lymph node staging, then these patients, by virtue of having substantial LVSI, pathological node negative patients, we tend to treat them with vaginal brachytherapy alone. Whereas patients who have not undergone lymph node dissection and have extensive LVSI, we tend to give post-op adjuvant external beam radiotherapy. Again, this is based on POTEC 2 study as well as the Swedish trial and GOG 99. Very important for stage 2, which is now in high intermediate risk group. For stage 2, if the patient has low grade and LVSI is negative, then such patients could be offered brachytherapy alone. Whereas if stage 2, high grade and LVSI positive, these patients will definitely receive external beam radiation, and in a research setting may also be offered chemotherapy as of the evidence seen from POTEC 2 or POTEC 3 or GOG 25 study. The ongoing study is the POTEC 4A, where they have integrated molecular classification and are currently recruiting patients by randomizing these patients based on the molecular risk profile and defining them into favorable group if polymutation is seen, or MMR deficient, then intermediate risk group, or patients who have substantial LVSI and P53 mutated, then such patients are classified as unfavorable group. And depending on this category, patients are offered observation in favorable group, vaginal brachytherapy in the intermediate group, and for unfavorable molecular classification, external beam radiotherapy is defined in a randomized fashion. And this is compared with standard treatment of vaginal brachytherapy for this high intermediate risk group. And so far, roughly around 350 plus patients have been recruited out of 500. And in a couple of years, we should have some early outcome results for this study. For the high risk group, which consists of stage 3, stage 4A with no residual disease, usually patients receive external beam radiation, either with concurrent chemotherapy followed by adjuvant chemotherapy, or sequential radiotherapy and chemotherapy. And these are based on the 2 randomized trials, that is POTEC 3 and GOG 258, which were published recently in last couple of years. For type 2 histology, P53 mutated tumors with myometrial invasion, similar options of concomitant of chemo, radiation, or chemotherapy alone have also been can also be offered. What is lacking in the literature is the higher stage polymutated tumors, where most of the patients have received adjuvant treatment by the virtue of staging. However, in polymutated tumors, we still need to have evidence for further recommendations. I think Professor Jaya Ghosh will go into the details of these trials. What I wanted to emphasize here is that I've shown the trial design to highlight what concomitant chemotherapy schedule was given in POTEC 3, which can be implemented in clinical practice. For example, 700 odd patients were randomized to pelvic chemoradiation with 2 cycles of cisplatin 50 milligram per meter square 3 weekly during radiation, followed by 4 cycles of paclitaxel and carboplatin, and was compared with pelvic radiation alone. And in GOG 258, the concomitant chemoradiation was similar to what was seen in PROTECT 3, versus the other arm was adjuvant chemotherapy, paclitaxel and carboplatin for 6 cycles. And what I wanted to highlight was that although both the studies showed that they had a common arm of chemoradiation, what I've shown here is that the 5-year survival for patients with stage 3 who received concomitant chemoradiation in PROTECT 3 was 71%, whereas in GOG 258, it was shown roughly around 60%. And I'm not sure why this difference of 10% in progression-free survival or failure-free survival in similar cohort of patients, one cohort of patients coming from Netherlands, the other cohort coming from US. And if you go into the details, what I've highlighted in the arm 3 and 4 are the PROTECT and GOG 258, where the common arms of concomitant chemoradiation are highlighted. And you can see here in this busy table that if we offer chemotherapy alone, the local as well as loco-regional relapses are higher as compared to patients receiving either radiation alone or concomitant chemoradiation. However, if you see the systemic relapse row, the systemic relapses are moderately less if you give chemotherapy alone as compared to concomitant chemoradiation. Suffice to say that I would be more comfortable in offering these patients of high risk combination of both external beam and chemotherapy in either concurrent setting followed by adjuvant, or similar to or give radiation first and then chemotherapy later on, or switch it to chemotherapy and radiation alone. And for molecular classification, I'm sure Jaya Ghosh will go into details. This continues. The molecular classification shows a significant difference in the outcome. Especially you can see P53 abnormal tumors definitely need to be treated aggressively so that the outcomes are better. Whereas in poly, you need not treat them with aggressive treatment. So maybe in future, poly mutated, even advanced stages may not require even adjuvant radiation for such tumors, especially with the favorable outcome which is seen in these in this study. What are the clinical implementation of the molecular markers? Definitely in preoperative risk stratification, it could be helpful to tailor diagnostic and surgical management, especially when you want to offer a fertility preserving option, as Dr. Bafna mentioned earlier. And in post-operative setting, we would definitely wait for PROTECT 4A results, depending on which we could tailor the treatment. And even more important about molecular markers is that if we are able to implement these molecular markers, we have various targeted therapies lined up. For example, in P53 tumors, we have PARP inhibitors, we have Herceptin, which is being utilized. In MMRD and P53 abnormal tumors, there are studies where the pembrolizumab as well as levodopa is also being experimented and researched. And last but not the least, in P53 tumors, Herceptin is also being evaluated in more advanced and metastatic disease. And for advanced disease, as I mentioned earlier, primary surgery debulking, if at all, should be considered if feasible. If not, these patients would go for systemic therapy, and upfront surgery as and when required. Delayed surgery could be offered for advanced stages or metastatic disease. So in summary, what you could do is you could paste this slide on your computer when you're evaluating a patient. You classify the patients in the low risk, and such patients would go for close observation and follow-up. If patient falls in intermediate risk group, then these patients typically would be offered vaginal brachytherapy with the close observation offered to patients who have favorable prognostic factors, for example, age less than 60 and low-grade tumors. For high intermediate risk group, if patient has not undergone pelvic lymph node dissection, we tend to give pelvic radiation. And for high risk, a combination of chemoradiotherapy is offered. And this combination depends on the institutional practice and the patient compliance to aggressive treatment of chemo and radiation. Last two slides on how to treat with radiotherapy. This is a slide which shows in detail vaginal brachytherapy. After hysterectomy, these patients have to be offered adjuvant brachy alone. Typically, we treat upper third of vagina to a length of 3 to 5 centimeters of upper vagina, and the doses are usually in a high dose rate brachytherapy are usually 3 to 4 fractions of 6 to 7 gray given once or twice weekly over 2 to 3 weeks. Why this is important is that in a couple of decades back, there was an understanding that the whole vagina has to be radiated with brachytherapy, and this usually would land up with severe vaginal morbidity, and these patients would have poor quality of life. However, it is very clear, and the evidence is very much in favor of treating only the upper third of vagina. If patient qualifies for external beam radiotherapy, as in high intermediate or high risk, these patients should be offered a state-of-art external beam radiation technique in the form of IMRT or VMAT, so that you can reduce the doses to the small bowel, the rectum, and the bladder, so that these patients have less toxicities and better tolerance to external beam. And this becomes vital, especially when you are giving a combination of external beam radiotherapy and chemotherapy, either in the form of sandwich, concomitant, or adjuvant. With this, I would like to thank the organizers once again, and stay safe. Thank you.